picture the scene. It's a wet, miserable Tuesday evening in A&E.
Oh, we've all been there. The waiting room is absolutely heaving.
Exactly. The monitors are chiming relentlessly, and a patient walks through the double doors. They're still wearing their damp cycling gear, the cleats clicking awkwardly on the linoleum. Or, maybe it's a builder in a high-vis jacket covered in brick dust.
But the posture is always identical, isn't it?
Always. They are hunched over, clutching their injured arm tightly against their chest, supporting the elbow with their good hand, and looking just utterly miserable. They've taken a massive high-energy fall directly onto the point of their shoulder.
Right, a classic mechanism.
So you get them into a cubicle, send them for imaging, and the radiograph goes up on the screen, and there it is, a mid-shaft clavicle fracture.
And not just a hairline crack, I imagine.
No, it's significantly displaced.
Yep.
The bone ends are completely overlapping, and when you look at the patient's actual chest, that sharp spike of the proximal fragment is tenting the skin so aggressively, it looks like a tent pole about to rip straight through the canvas.
It's a very visceral injury.
Yeah.
You can see the deformity from the end of the bed.
You really can. Now, for 50 years, the immediate response from the orthopedic team staring at that film was practically a reflex. We'd find a broad arm sling, prescribe some heavy paracetamol and perhaps a mild opiate, and look the patient in the eye with absolute confidence to reassure them it would heal beautifully on its own.
We treated almost every single clavicle fracture non-operatively. It was just the dogma.
Right. To do otherwise was considered unnecessarily aggressive. But today, sending that specific patient home with just a sling and a pat on the back could very well be viewed as clinical negligence.
It's a massive U-turn.
It really is. So joining us on this deep dive is Professor Mo Imam to help us contextualize the sheer volume of research on this single bone. It's brilliant to have you here to unpack this.
Thanks so much for having me. It's a topic I'm incredibly passionate about because that historical blind spot you mentioned is one of the most fascinating cautionary tales in modern orthopedics.
How did an entire specialty get something so fundamentally wrong for so long? I mean, the pendulum swung wildly from conservative management over to a surgical frenzy where we were plating almost everything. And now we're trying to find our footing in a nuanced, evidence-based middle ground.
The clavicle is just a deceptive piece of anatomy. On a standard two-dimensional chest radiograph, it looks incredibly straightforward. It's just a subcutaneous strut,
Yeah, you can feel it right under the skin.
Exactly. It looks mechanically simple. But when that strut snaps, the entire biomechanical chain of the shoulder girdle collapses in ways that are profoundly complex. We spent decades staring at the bone itself, completely ignoring the complex web of resting muscle tension, ligamentous support, and complex shoulder kinematics that rely entirely on that single bone maintaining its anatomical length.
And I really want to break down exactly how we miss that complexity. We aren't just going to rattle through classifications today. We're going to build a modern, defensible, patient-centered framework for anyone working in trauma.
That's the perfect goal.
Because whether you are a trauma surgeon staring at a complex radiograph at 2 in the morning or a sports physician advising an elite athlete on return to play, this discussion will completely redefine your clinical pathway. The old rules simply no longer apply.
They really don't. We have to throw the old rulebook out entirely.
So let's start by dissecting that historical dogma. Why was the entire global orthopedic community so utterly convinced that conservative management was the absolute gold standard? What was the actual foundation of that belief system?
Well, the foundation was built almost entirely on observational data from the mid-20th century. You're looking mostly at the work of Neer in the 1960s and then Rowe shortly after.
And their work basically dominated orthopedic teaching programs for generations.
Absolutely dominated. It was taught as undeniable gospel to every medical student. The prevailing narrative was that clavicle non-unions were exceedingly rare.
What was the figure they usually quoted?
The historically quoted figure was a non-union rate of roughly 1%.
Just 1%. Wow.
Right. And if you operate under the assumption that 99% of these fractures will heal independently, well, surgical intervention seems like madness.
Especially when you consider the historical context of surgery in the 70s and 80s.
Exactly. The implants were bulkier, the infection risks were significantly higher, and the anatomy, the clavicle sits directly superior to the brachial plexus and the subclavian vessels.
Right, the real danger zone.
Yeah, a drill plunging too deep meant devastating, life-altering neurovascular injury. So Conservative management wasn't just a preference, it was seen as the only ethically sound choice to protect the patient from catastrophic surgical complications.
It makes perfect logical sense if that 1% figure is real. But that is the crux of the issue, isn't it? The early 2000s roll around and that 1% myth gets completely dismantled.
Dismantled is the right word.
I'm thinking specifically of the Canadian Orthopedic Trauma Society, the COTS trial, published in 2007, and then Robinson's RCT. Those papers hit the trauma community like an absolute earthquake.
They completely rewrote the rulebook because they fundamentally changed the methodology of how we study these injuries. Previous retrospective studies, they grouped all clavicle fractures together.
So they were mixing tiny, non-displaced hairline cracks with massive displaced comminuted disasters.
Exactly that. And then they averaged out the healing rate. So, of course, the overall non-union rate looked incredibly low.
Ah, I see.
But the COTS trial and the Robinson RCT stopped doing that. They specifically stratified the fractures. They isolated the exact morphological subset you described in your opening scenario, the completely displaced midshaft fracture.
And what happens when you look exclusively at those severe injuries?
The actual non-union rate is vastly higher than historically quoted. It is nowhere near 1%. Modern series show that for displaced midshaft fractures managed conservatively, the non-union rate sits somewhere between 15 and 20%.
15 to 20%. I still struggle to wrap my head around how an entire medical discipline missed a failure rate of 1 in 5. Did the biology of human bones change, or were we simply failing to ask patients the right questions for 50 years?
We definitely weren't asking the right questions. We weren't really looking at the patient at all. Historically, orthopedic surgery was intensely, almost exclusively focused on radiographic union.
Treating the X-ray, essentially.
Precisely. A patient would come into the clinic, the surgeon would look at the X-ray, see a hazy cloud of white callus formation bridging the gap, declare the bone healed, and discharge the patient.
Even if the patient was still struggling.
Yeah, there was no systematic measurement of how the patient actually functioned in their daily life. We completely ignored patient-reported outcome measures or PROMs.
Right.
If the patient complained of a deep ache when reaching for a high shelf or felt their shoulder fatigue quickly when carrying shopping, it was often just dismissed as normal post-traumatic stiffness.
Which brings up the whole concept of malunion, because even if the bone technically bridges and heals, if it heals in a terrible position, the patient still suffers. And McKee's work really highlighted this, didn't it?
McKee's research was the final nail in the coffin for the universal conservative approach. He proved that modern evidence has to evaluate more than just radiographic union. The clavicle is the sole bony articulation connecting the entire axial skeleton to the upper limb.
It's the only bony link.
Exactly. It acts as a highly calibrated strut, holding the scapula in its optimal position on the posterior chest wall. So if that clavicle heals with significant shortening or severe angulation of malunion, the scapula is physically forced to protract and rotate anteriorly.
It literally slides forward around the rib cage.
It does. And when the scapula slides forward, the resting tension of the entire rotator cuff and all the periancapular muscles is completely disrupted. The muscles are either overstretched or slackened. They lose their mechanical advantage.
So what does that look like clinically for the patient?
Patients with significant clavicular malunions frequently present with scapular dyskinesia. They report chronic, poorly localized pain with overhead activities, rapid muscle fatigue, and a demonstrable loss of peak shoulder strength.
Wow.
So the clinical question fundamentally shifted. It was no longer just, will this bone eventually fuse together?
Right.
It became, will this bone heal in a precise anatomical position that provides the patient with a functionally normal, pain-free shoulder girdle?
And having established that the old dogma was deeply flawed and understanding the severe functional consequences of malunion, we're left with a really difficult clinical reality because we can't swing to the opposite extreme and plate every single mid-shaft fracture that walks through the door, can we?
Definitely not. Surgery carries profound risks.
Right. We need a highly selective triage system. We have to define exactly who requires surgical intervention, and that forces us to look closely at anatomy and morphology.
It does.
So the traditional classifications, Allman and Neer, they are everywhere in the textbooks. Do they actually help us make the surgical decision in the trauma day?
They're useful for initial triage, sure, but they fall completely short for detailed decision-making. Allman and Neer primarily classified fractures based on anatomical location.
Dividing the bone into the medial, middle, and lateral thirds.
Exactly. And knowing the location is important because it dictates the general muscular deforming forces at play. However, simply knowing a fracture is in the middle third doesn't tell you if it needs a plate.
Right, it just gives you the postcode of the injury.
That's a great way to put it. It gives you the postcode, but morphology tells you if the house has completely collapsed.
I like that.
For clinical decision-making, we rely heavily on the Robinson classification, or the AO classification, because they detail the specific fracture morphology. They tell us if the bone is simply cracked, completely displaced, angulated, or shattered into multiple comminuted fragments.
And when we look at that midshaft morphology, modern evidence repeatedly points to three major red flags. The big three predictors of poor non-operative outcome.
Yes, the big three are critical.
So if you're trying to identify the patient destined for that 20% non-union group, what specific features are you hunting for on that initial film?
The big three are highly reliable indicators of biological failure. The first is shortening of the clavicle by greater than 20 millimeters.
Okay, 20 millimeters.
The second is complete displacement, meaning there's absolutely zero cortical contact between the proximal and distal main fragments.
Okay.
And the third is significant comminution, particularly the presence of a transverse Z-type wedge fragment between the main bone ends.
So when you see those three features,
You are looking at a biomechanical environment that is fundamentally hostile to primary bone healing.
let's isolate that shortening threshold, because 20 millimeters is a very specific, frequently cited number. Why does the entire mechanics of the shoulder girdle fail so predictably once the clavicle shortens past that 2-centimeter mark?
It's entirely about the massive muscular forces acting on the free-floating bone segments. When the midshaft snaps and completely displaces, you lose the structural integrity of the strut. Immediately, the sternocleidomastoid muscle, which attaches to the medial fragment, violently pulls that proximal piece of bone superiorly and posteriorly towards the neck.
And at the same time?
At the same time, the entire weight of the arm, gravity, and the immense pull of the pectoralis major and latissimus dorsi muscles drag the distal fragment inferiorly and medially towards the chest.
They're basically bypassing each other like two trains on parallel tracks.
Exactly. And if the initial trauma energy forces those fragments to bypass each other by more than 20 millimeters, the resting tension of those massive muscle groups is entirely lost.
They just give up.
The muscles essentially go into spasm, locking the shortened position in place. The interfragmentary strain, the micromotion between the bone ends, becomes far too high for delicate primary callus formation to survive.
So it creates a sort of self-perpetuating cycle of displacement.
Precisely. The muscles pull, the bone shortens further, the strain increases, the blood supply to the fracture hematoma is continually sheared off, and the biology just eventually gives up, leading to a non-union.
I always try to visualize the clavicle like the main horizontal load-bearing strut of a complex suspension bridge.
Oh, that's a brilliant analogy.
The cables supporting the bridge are your trapezius, your pectoralis, your sternocleidomastoid. If you suddenly take a hacksaw, cut the main horizontal strut, and shorten it by an inch, the entire tension system of the bridge is destroyed.
Absolutely destroyed.
Some cables go completely slack, while others are stretched to their breaking point. The whole structure just sags and it loses its ability to bear heavy loads.
And functionally, the patient's shoulder literally sags forward and inward. Because the fulcrum of the scapula is no longer held firmly in its correct spatial orientation, the rotator cuff muscles cannot generate normal torque.
So that's why a patient with a clavicle shortened by 25 millimeters will profoundly struggle to lift a heavy box over their head, even after the bone has technically healed.
Exactly. The biomechanics are just fundamentally altered.
But translating this to the chaotic environment of A&E brings up a major practical issue. I have seen junior doctors squinting at a standard AP chest radiograph, holding up a plastic ruler to the screen, trying to definitively measure 20 millimeters of shortening.
It's a nightmare.
But the magnification and the projection angles of a standard chest X-ray make that measurement wildly inaccurate, don't they?
Using a standard AP chest radiograph to measure clavicular shortening is a dangerous clinical trap. The clavicle is an S-shaped bone that lies obliquely across the superior thorax.
Right, it's not just flat.
No, not at all. When you take a standard AP view, the overlapping bone ends project artificially. You're looking at a three-dimensional deformity crushed into a two-dimensional plane from the wrong angle.
So what should they be asking for instead?
To obtain an accurate measurement, you must request a dedicated clavicle view, specifically a 15 to 30 degree cephalic tilt view.
So tilting the X-ray beam upwards?
Yes. Angling the beam upwards projects the clavicle clear of the upper ribs and the apical lung fields. This dedicated view gives you a true representation of the superior-inferior displacement and, crucially, the true longitudinal shortening.
And how exactly should clinicians measure this shortening on that dedicated view?
You should measure from the center of the medial fragment to the center of the lateral fragment. Ideally, you would compare the total length of the fractured clavicle to a dedicated film of the uninjured contralateral side.
But practically speaking,
obtaining bilateral clavicle views in a busy acute trauma setting is often very difficult to justify to the radiography team. So you rely on the fragment overlap on the tilt view.
right. Let's assume we have secured the correct imaging. We measure the shortening on the cephalic tilt view, and it's undeniable. 28 millimeters of shortening. The fragments have zero cortical contact, and there's a large vertical butterfly fragment sitting in the soft tissue.
A catastrophic failure.
The suspension bridge has collapsed. It requires mechanical intervention to restore length and stability. The trauma surgeon now has to select a tool from the surgical toolkit.
And this is where it gets highly technical.
Exactly. Let's delve into the actual mechanics of the operations, starting with the fierce debate between plates and intramedullary nails for mid-shaft fractures.
Well, plating remains the undisputed workhorse for displaced mid-shaft clavicle fractures. It provides immediate, rigid, mechanical stability.
But even within plating, there's controversy.
Oh, massive controversy. There's a fierce ongoing debate regarding the anatomical placement of the plate. Should it sit on the superior surface or the anterior-inferior surface?
Let's pull those two options apart. What is the fundamental biomechanical argument for placing the plate directly on top on the superior surface?
Superior plating operates on classic tension band principles. As we established, the deforming forces of gravity in the arm pull the distal fragment downwards. This bending force puts the superior surface of the clavicle under extreme tension. The bone is literally trying to pull apart at the top, while the inferior surface is under compression.
So by putting the plate on top,
By applying a robust, anatomically contoured titanium plate directly onto the superior surface, you are placing your fixation device exactly on the tension side of the bending moment.
it's like bending a thick wooden branch over your knee. The top of the branch stretches and splinters, while the bottom of the branch compresses and wrinkles. If you wanted to stop the branch from snapping, you'd duct tape the top, stretching side, not the bottom.
That's a perfect visualization. You're converting the distracting tension forces into compressive forces across the fracture site.
Which is what you want for healing.
Exactly. Biomechanically, superior plating is exceptionally rigid. It allows the surgeon to achieve perfect anatomical reduction and provides enough stability for the patient to begin early, active mobilization of the shoulder without fear of the hardware failing.
But there is a glaring anatomical problem with the superior surface, isn't there? The clavicle has virtually no soft tissue coverage on top. It's just skin and a really thin layer of platysma muscle.
Yes, very thin.
Doesn't superior plating leave the patient with a highly prominent, palpable piece of titanium sitting right under their collar line?
That is the most significant clinical drawback,
Yep.
and it is a major source of patient dissatisfaction. Superior plates are notorious for causing chronic hardware irritation.
I can imagine.
Patients frequently complain that the plate prominently rubs against backpack straps, seat belts, or heavy winter coats. In thin patients, the plate is completely visible beneath the skin.
And what about the surgical risks of going from the top?
That's the other major issue. From a surgical safety perspective, the screw trajectory for a superior plate is directed inferiorly, straight down. The drill bit is aimed directly down towards the subclavian vein, the subclavian artery, and the brachial plexus. Plunging a drill bit even a few millimeters too deep past the far cortex during a superior approach can result in a catastrophic, life-threatening hemorrhage or permanent nerve damage.
Which perfectly explains why the anterior-inferior plating technique has seen such a massive surge in popularity among trauma surgeons recently.
Absolutely. The anterior-inferior approach mitigates several of those risks. By placing the plate on the front, lower edge of the bone, the screw trajectory is directed posteriorly and superiorly.
So you're drilling away from the danger zone.
Exactly. The drill bit is aiming away from the critical neurovascular bundle, drastically increasing the safety margin of the procedure. Additionally, the cortical bone density on the anterior-inferior aspect is often slightly thicker, providing excellent screw purchase.
And what about the hardware irritation for the patient? Does it solve that?
It's significantly reduced. Because the plate is tucked underneath the natural anterior overhang of the clavicle, it's shielded from direct pressure. It's far less prominent beneath the skin.
That makes sense.
Studies consistently show that anterior-inferior plating results in significantly lower rates of subsequent surgeries for hardware removal due to soft tissue irritation.
So, superior placement offers optimal biomechanical tension banding, while anterior-inferior placement offers a much safer biological profile and better cosmesis.
That's the trade-off.
But regardless of where you put the plate, the traditional open procedure requires a relatively large surgical incision. You have to slice through the skin, dissect down to the bone, strip away the periosteum, and clear out the fracture hematoma to see what you're doing.
You do. It's an invasive process.
And that hematoma is packed with essential osteoprogenitor cells.
Yeah.
You are essentially destroying the body's natural biological healing environment to install mechanical stability. Does that biological destruction explain the renewed interest in elastic stable intramedullary nailing, or ESIN?
Yes. The biological cause of open plating is the primary driver behind the evolution of intramedullary techniques. ESIN attempts to provide mechanical stability without the severe soft tissue devastation of a large open approach.
How does it actually work in practice?
The technique involves making a tiny 1 centimeter incision, usually just lateral to the sternoclavicular joint. The surgeon opens the medullary canal of the bone and, under live fluoroscopic X-ray guidance, threads a flexible titanium nail through the hollow center of the clavicle, driving it across the fracture site and into the distal fragment.
The concept sounds incredibly elegant. You're essentially threading a highly engineered splint directly inside the bone, leaving the fracture site completely untouched.
From a biological standpoint, it is incredibly elegant. The evidence clearly demonstrates that ESIN results in significantly smaller incisions, minimal periosteel stripping, and total preservation of the fracture hematoma.
And patients must love the tiny scar.
Cosmetically, young patients greatly prefer it. The bone heals via robust secondary callus formation because the biological environment is undisturbed. However, we must be very clear, ESIN is not a universal panacea. It has severe mechanical limitations.
I've always struggled to picture how a smooth, flexible nail sitting inside a hollow tube prevents the bone fragments from spinning around. It doesn't use locking screws to hold the bone in place like a plate does.
You have hit on the exact biomechanical weakness of the system. ESIN does not provide robust rotational stability. Because it is a single, flexible nail, the bone fragments can still rotate around the axis of the nail.
So it's not for every fracture.
Definitely not. Therefore, ESIN is strictly indicated only for simple, two-part midshaft fractures, or perhaps simple wedge fractures where the surrounding cortical shell is largely intact and can physically interlock to prevent rotation.
What happens if you try to use it on a shattered bone?
If you attempt to use an ESIN in a highly comminuted, shattered fracture, the fracture will simply collapse longitudinally like a telescope sliding shut along the nail, leading to massive shortening and failure.
Wow, just telescoping shut. And what about the practicalities of a flexible titanium nail sitting inside a dynamic, constantly moving shoulder girdle? Surely the micromotion of daily life affects the hardware. I imagine a nail migrating inside the medullary canal is not ideal.
It is a very common complication, unfortunately. Because the nail is flexible and the shoulder is highly mobile, the micromotion frequently causes the nail to slowly back out at the medial insertion site near the sternum.
Ouch!
Exactly. This prominent tip of titanium causes severe skin irritation and pain. Consequently, the hardware removal rate with ESIN is extremely high.
So they have to come back to theater.
Almost always. While ESIN offers a lower initial infection rate and superior early cosmesis, the patient almost universally requires a minor second procedure to remove the nail once the fracture is consolidated.
So, if you have a young, athletic patient with a simple two-part fracture who cares deeply about a minimal scar, EAN is a fantastic option, provided they consent to the likelihood of a second removal surgery.
Correct.
But for complex, shattered fractures, rigid plating remains the undisputed gold standard.
Without a doubt.
However, we must discuss the darker realities of surgical intervention. We're trying to avoid a 20% conservative non-union rate, but surgery is not a free pass. We are exposing patients to tangible, sometimes severe morbidities. We really need to look those risks in the eye.
It is the most critical part of the preoperative consultation. Surgical fixation successfully drops the non-union rate from roughly 20% down to about 1 to 2%.
Which is a massive triumph.
It is. However, it introduces a completely new spectrum of iatrogenic risks. Infection is a primary concern. The deep infection rate for clavicle plating hovers between 2 and 3%.
And a deep infection is a disaster, isn't it?
A total disaster. It often necessitates a return to theater to remove all the hardware, followed by weeks of intravenous antibiotics, leaving the patient with an unstable, infected non-union.
And we briefly mentioned the neurovascular risks earlier with the drill bits.
Yes, while major vascular injury to the subclavian vessels is statistically rare, when it occurs, it is a life-threatening hemorrhage requiring immediate cardiothoracic intervention.
Terrifying.
But a much more common, yet incredibly frustrating complication involves the supraclavicular nerves.
The small sensory branches that drape over the collarbone.
Correct. The surgical incision for a midshaft plate almost inevitably dissects through or aggressively retracts these delicate cutaneous nerves.
So what happens to the patient?
As a result, a vast majority of patients wake up from surgery with a prominent patch of profound numbness or altered sensation over their anterior chest wall, extending down towards the nipple.
Does it go away?
While the area of numbness often shrinks over several months, it is frequently permanent. So the surgical decision is never a simple binary choice. It is a complex, shared decision-making process where the surgeon and the patient must carefully weigh the functional detriment of a potential malunion against the very real, tangible morbidities of open surgery and general anesthesia.
So the midshaft clearly operates under a robust set of biomechanical rules, and we have a wealth of trial data to guide our toolkit selection. But clavitins don't always break conveniently in the middle, do they?
No, they certainly don't.
As the fracture line moves towards the extreme edges of the bone, the entire biomechanical landscape changes dramatically. The influence of the acromioclavicular joint, the AC joint, and the incredibly powerful coracoclavicular ligaments fundamentally rewrites the surgical rulebook.
It's a completely different ballgame.
Let's shift our focus to these tricky extremes, starting with the lateral end. Why are lateral fractures so notoriously prone to non-union compared to the midshaft?
Lateral end fractures, which we traditionally classify using the Neer and Craig classifications, present a completely different biomechanical nightmare.
How so?
In the midshaft, we deal with the SCM and the pectoralis. At the lateral end, the fundamental issue is the anatomical relationship between the precise fracture line and the coracoclavicular, or CC, ligaments, specifically the conoid and the trapezoid ligaments.
These are the incredibly thick, dense bands of tissue that essentially suspend the entire arm from the clavicle.
Exactly. They are the primary suspensory stabilizers of the upper limb. When you encounter a completely displaced Neer type 2 fracture, the fracture line occurs just medial to those CC ligaments.
Okay, so the break is inside of the ligaments.
Right. This means the medial proximal segment of the clavicle is completely freed from its ligamentous anchor to the scapula. However, those massive CC ligaments remain firmly attached to the tiny distal fragment of the clavicle.
So you have a tiny piece of bone attached to the whole arm and a massive piece of bone attached to the neck.
This creates an incredibly violent, unbalanced, deforming force. The entire weight of the arm pulls that tiny lateral fragment radically inferiorly. Simultaneously, the massive trapezius muscle, which inserts broadly onto the proximal fragment, goes into spasm and pulls that large segment violently superiorly and posteriorly.
It's a tug of war.
A brutal anatomical tug of war. The two bone ends are ripped apart in completely opposite directions. Because the distal fragment is anatomically tiny, there's almost no surface area available for bone healing.
Which explains the high non-union rate.
Exactly. That severe mechanical instability makes conservative management of displaced Neer type 2 fractures highly prone to non-union. Historical literature reports non-union rates as extraordinarily high as 30 to 40% if left alone.
With a failure rate approaching 40%, operative intervention is heavily indicated. But the surgical solutions for the lateral end are arguably more controversial than the midshaft.
They're fiercely debated.
We see two prominent, fiercely defended camps of surgical thought here. The rigid biomechanics of the hook plate versus the flexible biological approach of the suture button techniques. Let's tackle the hook plate first.
Okay.
When you look at an x-ray of a hook plate, it looks incredibly aggressive. It's a thick steel plate with a sharp prong that hooks directly under the acromion. It looks brutal, but it effectively solves the tug of war.
The hook plate provides undeniable, unparalleled, rigid mechanical superiority. The plate is fixed to the superior surface of the medial fragment with locking screws. Then, the specialized hook extension passes under the posterior aspect of the acromion.
Grabbing it from underneath.
Exactly. By leveraging upwards against the dense undersurface of the acromion, the plate physically forces the medial clavicle down into anatomical alignment, utterly neutralizing the massive superior pull of the trapezius.
So it forces the bone ends to meet.
It holds the tiny lateral fragment perfectly still, allowing for solid, predictable bony union.
But there's a massive inherent design flaw with the hook plate, isn't there? It assumes the shoulder joint is a static piece of architecture, but it isn't. You cannot just leave that hook in there forever.
It is absolutely contraindicated to leave a hook plate in permanently. This is perhaps the most critical clinical pearl regarding lateral clavicle trauma. The AC joint is an incredibly dynamic articulation.
Right.
It undergoes complex rotational, translational, and pivoting movements during any shoulder elevation or rotation. It is not a fixed hinge. If you rigidly lock the dynamic clavicle to the dynamic acromion using a solid block of titanium, you completely block that natural physiological motion.
It's like driving a massive steel nail through a swinging door hinge. The door desperately needs to rotate to open, but the rigid nail stops it. If you force the door to move, the metal is going to violently grind away at the wood.
That analogy perfectly describes what happens inside the shoulder. As the patient rehabilitates and moves their arm, the unyielding metal hook literally grinds into the undersurface of the acromion. The localized pressure is immense. Over a period of months, this relentless friction causes severe acromial osteolysis. The bone of the acromion literally dissolves and resorbs under the abnormal mechanical stress.
It dissolves the bone.
Yes. It physically wears it away. Furthermore, the sheer physical bulk of the hook occupies the tight subacromial space, frequently leading to severe, agonizing rotator cuff impingement.
So when a surgeon opts for the biomechanical security of a hook plate, they aren't just planning one surgery. They are effectively committing the patient to a mandatory two-stage procedure from the moment they make the first incision.
Correct. The surgeon must factor in the second operation for hardware removal from day one, and this must be explicitly detailed during the initial patient consent process.
When do they usually take it out?
Usually, the second surgery is scheduled for 3 to 4 months post-operatively. You wait just long enough for radiographic union to be confirmed, but you must race to remove the plate before severe, irreversible osteolysis destroys the acromion.
That significant biological burden and the logistical nightmare of scheduling a mandatory second general anesthetic is exactly why the alternative camp, the suture button techniques, has gained such massive traction globally. How do these biological systems compare to the rigid metal hook?
Suture button techniques, such as the dog bone or the tightrope systems, represent a paradigm shift towards a purely biological approach. Instead of attempting to overpower the anatomy with rigid metal levers, we attempt to reconstruct it.
Rebuild the ligaments.
Exactly. The technique involves drilling small tunnels through both the clavicle and the coracoid process of the scapula. We then pass ultra-high-strength, non-absorbable synthetic sutures through these tunnels, securing them with small metallic or polymer buttons on the bone surfaces.
And then you just tighten them.
By tightening these sutures, we physically reduce the clavicle and effectively reconstruct the torn coracoclavicular ligaments.
It mimics the native anatomy. You're replacing torn biological cables with high-tech synthetic cables.
Exactly. The biological advantage is immense. There is no massive rigid hook grinding against the acromion, preventing osteolysis entirely.
And the shoulder can still move?
Yes. Because the synthetic sutures possess a slight degree of inherent elasticity, the construct restores stability while still permitting the vital microscopic rotational motion at the AC joint. It is physiologically far healthier for the shoulder girdle over the long term.
And no second surgery.
Crucially, routine removal of the suture buttons is generally not required, sparing the patient that second surgery.
It sounds like the perfect solution. Why hasn't it completely replaced the hook plate?
Because the surgical technique has a notoriously steep learning curve. Drilling the coracoid process accurately is technically demanding. The coracoid is surrounded by complex neurovascular anatomy. A misplaced drill bit can cause severe damage.
Oh, I see.
Often, this procedure is done minimally invasively or even arthroscopically, requiring specialized skills. Additionally, in severely comminuted lateral fractures where the lateral fragment is shattered into dust, sutures alone may not provide adequate rotational control of the bone fragments.
So you might still need plates anyway.
Sometimes we have to supplement the sutures with tiny microplates. But if executed correctly by an experienced surgeon, the biological benefits heavily outweigh the risks.
That is a brilliant breakdown of the lateral complexities. Before we move on to complications, we must briefly touch upon the medial end. Fractures here are statistically quite rare. But when a patient rolls into the trauma bay with a medial end injury, why does the atmosphere suddenly become so tense? When should a medial end fracture genuinely raise our heart rate?
Medial end fractures, particularly those involving the sternoclavicular joint, should instantly spike your index of suspicion. The orthopedic concern takes a backseat to the immediate, potentially life-threatening anatomical realities of what lies immediately deep to that joint.
We're talking about the superior mediastinum.
Exactly. The most critical vascular real estate in the body, the brachiocephalic vein, the superior vena cava, the aortic arch, and the major branches of the brachial plexus, along with the trachea, the esophagus, and the apical dome of the pleura. They are located literally millimeters posterior to the medial clavicle.
It ceases to be an orthopedic issue and instantly becomes a cardiothoracic trauma scenario.
Precisely. Now, thankfully, the vast majority of medial fractures and sternoclavicular dislocations displace anteriorly. The bone pops out forward.
Which looks awful, but is actually fine.
It looks cosmetically alarming, a large painful lump on the upper chest. But it is clinically benign because it's moving away from the danger zone. However, if the mechanism of injury involves a massive, high-energy direct blow to the anterior chest,
Like a steering wheel in a car crash.
yes, or a crush injury in a rugby scrum, driving that medial clavicle posteriorly, that is an absolute surgical emergency.
Because that sharp bone spike is now acting like a dagger aimed directly at the great vessels.
Exactly. A posterior displacement threatens to compress or lacerate those vital mediastinal structures. Crucially, standard radiographs are utterly useless for assessing posterior displacement at the medial end.
Because of all the overlapping ribs?
Yes, the overlapping shadows of the ribs and vertebrae make it impossible to see the depth of the joint. If you suspect a posterior medial fracture, especially if the patient exhibits any subtle, sinister signs,
Like what?
like subtle respiratory distress, stridor, dysphagia when swallowing, or venous engorgement in the neck indicating venous compression. You see any of that, cross-sectional imaging with a contrast-enhanced CT scan is absolutely mandatory without a second's delay.
You can't wait.
No. The surgical reduction of posterior displacement often requires having a cardiothoracic surgeon scrubbed and on standby in the theater in case of a massive vascular tear during the reduction maneuver.
That highlights just how high the stakes can get. Let's pivot to the brutal realities of practice. We've spent an hour discussing how to get it right. But whether we are managing a midshaft fracture conservatively or navigating the complex lateral extremes surgically, sometimes the primary plan simply fails.
It does. Biology doesn't always cooperate.
Exactly. The biology doesn't cooperate or the mechanics break down. The listener needs to understand how to navigate the ultimate devastating complication, the non-union. What happens when that 20% statistical risk becomes the actual suffering patient sitting opposite you in the clinic 6 months post-injury? The bone hasn't healed, they are in chronic pain, and their shoulder feels weak and unstable.
A symptomatic non-union is a thoroughly miserable existence for the patient. Every time they lift their arm, they feel a grinding, clicking sensation. They experience a profound, deep-seated ache and a pervasive sense of instability that prevents them from trusting their own arm.
And treating it isn't simple, is it?
Treating an established non-union is not a simple revision. The surgical salvage protocol for a clavicular non-union is arguably one of the most technically demanding and biologically challenging procedures in upper limb trauma. You cannot simply open the wound, throw a larger plate on it, and hope for the best.
Because the biological environment has completely declared failure. The body has actively given up trying to heal that specific area. What does that actually look like when you open the skin?
It is a stark biological dead zone. When you dissect down to a non-union, you do not find a healthy bleeding fracture. You find a pseudoarthrosis, a false joint.
A false joint.
The bone ends have become intensely sclerotic. They look like smooth, dead white ivory. The gap between the bones is filled with dense, avascular, rubbery, fibrous tissue.
And that stops the healing.
This fibrous plug acts like a shock absorber, completely preventing any osteogenic cells from bridging the gap. The local healing cascade is completely shut down.
So how do you forcefully restart a biological process that has been dormant for 6 months?
The salvage strategy relies heavily on two absolute non-negotiable pillars: violently returning the environment to a biologically active state and establishing absolute immovable mechanical stability.
Violently returning it, what does that involve?
Biologically, we must be ruthless. We sharply excise every millimeter of that rubbery, fibrous interposition tissue. Then we must aggressively decorticate the bone. Using a high-speed burr or an osteotome, we scrape away all that dead, sclerotic ivory bone until we reach fresh, healthy, profusely bleeding bone marrow on both sides.
You're trying to recreate the original injury.
We have to essentially trick the body into thinking a brand new fracture has just occurred.
And even then, scraping the bone isn't enough, is it? You have to bring in reinforcements.
Absolutely. Biological augmentation is almost universally mandatory in a salvage procedure. This almost always means harvesting autologous bone graft.
From the pelvis.
Yes. We typically make a secondary incision over the patient's iliac crest and physically chisel out a block of their own cancellous bone. We pack this pelvic bone graft tightly into the clavicle defect.
To bring in the live cells.
Exactly. This provides a massive influx of live osteoblasts, vital growth factors, and a structural scaffold to artificially jumpstart the stalled healing cascade.
That sounds incredibly invasive. And what about the mechanical side of the salvage? The forces that caused it to fail the first time are still there.
The mechanical fixation must be uncompromising. We utilize heavy-duty, locking compression plates, often longer and thicker than those used in primary trauma. The fixation must be rigid enough to completely neutralize those immense deforming forces we discussed earlier, ensuring absolutely zero micromotion at the fracture site.
The graft has to be protected.
The bone graft must be held in a perfectly still environment to successfully incorporate and bridge the gap. It is a highly successful salvage operation in experienced hands, but it is a major physiological insult with a significantly prolonged, painful recovery time for the patient.
This detailed look at the salvage procedure brings us to a vital transition in our decision-making framework. We've spent an hour deep diving into pure biomechanics, morphological classifications, tension band theories, and aggressive surgical techniques. But modern medicine cannot exist in a purely mechanical vacuum.
It really can't.
The evidence increasingly dictates that a patient's occupation, their psychological expectations, and their daily lifestyle matter just as much as the fracture morphology displayed on the X-ray screen. How do we integrate the holistic human pathway into this complex mechanical equation?
This is the precise intersection where the art of medicine meets the rigorous science of biomechanics. Guidelines from the British Orthopedic Association Standards for Trauma and NICE strongly emphasize moving away from paternalistic medicine and embracing a shared decision-making model.
Because you aren't just treating an X-ray.
You're not treating an isolated radiograph. You're treating a complex human being with unique functional demands.
Let's illustrate this with a hypothetical contrast. Imagine two patients presenting with the exact same radiograph. A displaced midshaft fracture with 25 millimeters of shortening. Patient A is a 24-year-old professional cyclist. Patient B is a 70-year-old retired accountant who spends their days reading and walking the dog. How does the counseling profoundly differ?
You must start by explicitly defining what success means to that specific individual. For the professional cyclist, their livelihood, their identity, and their income depend on an immediate return to rigorous, high-intensity training.
They need it fixed now.
They require absolutely perfect shoulder kinematics for aggressive bike handling. They simply cannot afford to endure a 12-week period of conservative uncertainty, only to discover they fall into the 20% non-union group, requiring a massive salvage surgery that ruins their entire competitive season.
So for them, surgery is almost mandatory.
For this elite athlete, early surgical fixation offers predictable, rigid stability. It allows for aggressive, immediate rehabilitation and a much faster, highly reliable return to elite, symmetrical function. The surgical risks are justified by the occupational necessity.
And conversely, the retired accountant.
The 70-year-old retired accountant places minimal functional demands on their shoulder girdle. They are not engaged in heavy overhead lifting or high-impact sports. Even if their clavicle heals conservatively with 20 millimeters of shortening and slight scapular dyskinesia, they are highly unlikely to notice any meaningful functional deficit in their daily routine of reading and walking.
So exposing them to the risks of surgery is harder to justify.
Exactly. For this patient, exposing them to the systemic risks of general anesthesia, the potential for permanent supraclavicular nerve damage, and the catastrophic risk of a deep prosthetic infection might be entirely medically unjustified.
You just have to be honest with them.
You clearly outline the 15 to 20% risk of non-union. Explain that we have robust salvage options available later if necessary, And frequently, they will sensibly and safely choose conservative management in a sling.
It is about perfectly matching the intervention to the biological and functional demands of the host, which leads us seamlessly into the most common, relentless question asked in every fracture clinic in the world. When can I return to sport?
Oh, the million-dollar question.
What are the concrete evidence-based timelines we should be providing, particularly after we have surgically plated a clavicle? Because patients often feel great at 2 weeks and want to play rugby.
Historically, orthopedics relied on arbitrary, calendar-based timeframes, 6 weeks in a sling, 12 weeks before lifting. But modern, evidence-based rehabilitation moves us entirely away from the calendar and strictly towards physiological timelines and functional milestones.
Because the metal makes them feel invincible.
After a rigid plate fixation, the pain drops dramatically because the bone is mechanically held together by heavy titanium. The patient feels cured. But the physiological timeline of callus formation, woven bone deposition, and true cortical bone bridging still takes an absolute minimum of 8 to 12 weeks.
So even if the plate is incredibly strong, the underlying bone itself is still biologically fragile. It's a race between the bone healing and the metal breaking.
Exactly. A titanium plate is strong, but it is not invincible. If it is repeatedly subjected to massive repetitive loads before the biological bone has healed enough to share the stress, the plate will undergo fatigue failure. It will simply snap in half.
So how do you manage the rehab?
Therefore, early mobilization protocols focus entirely on restoring range of motion to prevent adhesive capsulitis, a frozen shoulder, but strict load-bearing restrictions must remain in place. The most fiercely debated parameter is allowing a return to high-impact contact sports rugby, martial arts, competitive downhill mountain biking.
Because a massive, high-velocity direct impact to the shoulder could catastrophically bend the plate, snap the screws, or even worse, cause a complex periprosthetic fracture exactly at the edge of the plate where the rigid bone meets the flexible bone.
A periprosthetic fracture is a complete disaster. It is far harder to fix than the original injury. I counsel my athletic patients that a return to any contact sport is strictly, non-negotiably forbidden until two absolute criteria are met.
What are they?
First, we must have definitive, multi-angle radiographic evidence of robust cortical bone bridging across all cortices of the fracture site. But more importantly, second, they must have met specific, rigorous functional milestones.
It's not just about the x-ray, it's about muscle capability.
Precisely. The patient must demonstrate full, painless range of motion and totally symmetrical strength in their rotator cuff and periscapular muscles when compared to the uninjured side.
Why is the muscle strength so critical for the plate?
If their periscapular musculature is still weakened or atrophied from the injury, their shoulder joint is entirely unprotected against high-energy kinetic impacts. The muscles act as the shock absorbers. If the muscles fail, the force goes straight to the plate.
And the plate breaks.
For competitive contact athletes, achieving this level of symmetrical strength often pushes the true return-to-play timeline to the 4 to 6 month mark, regardless of how beautifully consolidated the X-ray appears at 8 weeks.
It's a sobering timeline, but it's driven by functional readiness, not just a healed white line on a computer screen. This has been an incredibly comprehensive exploration. Let's pull all of these intricate clinical threads together. We've covered an immense amount of ground today, from the SCM muscle forces to iliac crest bone grafts. What are the key, unforgettable clinical pearls our listeners must take away from this discussion to immediately apply to their practice?
If we distill the vast body of evidence into actionable points, there are 4 critical takeaways. First, the absolute, definitive death of the 1% non-union myth. You must remember and respect that a completely displaced midshaft fracture carries a severe 15 to 20% risk of non-union if treated with a sling.
A completely different world from what we were taught.
Second, internalize the morphological threshold of 20 millimeters. Shortening greater than 20 millimeters is your primary, glaring red flag for poor functional outcomes, scapular dyskinesia, and non-union, and it should heavily tilt the clinical discussion towards surgical intervention.
And for the lateral end.
Third, regarding the treacherous lateral end fractures, if you opt for the undeniable rigid biomechanics of a hook plate, you must accept and explicitly plan for the mandatory secondary operation for hardware removal to prevent catastrophic acromial osteolysis.
Plan for 2 surgeries.
Always. And finally, the paramount importance of holistic care. Match the surgical pathway to the patient's lifestyle. Treat the patient's functional demands, their occupation, and their expectations, not just the 2-dimensional shadow on the radiograph.
Outstanding summary. As we close this deep dive, I want to leave you, the listener, with a final forward-looking thought to ponder. As our understanding of bone biology reaches the cellular level, and as implant technology rapidly evolves at a staggering pace, particularly the advent of highly customized 3D printed titanium plates that perfectly match a patient's unique anatomical contours based on CT scans, will we see the pendulum swing yet again?
It's a fascinating prospect.
Will the ability to create ultra-low profile, mechanically perfect, biologically sympathetic implants that conform exactly to the S shape of the clavicle lead us to a future where we prioritize biological preservation even more over the rigid, heavy-duty, one-size-fits-all mechanical fixation of the past decade? It is a truly fascinating space to watch evolve. If this discussion refined your clinical pathway today, please take a moment to rate the show and share it with your colleagues in the trauma bay. Apply this robust, evidence-backed framework the next time you are sitting in the fracture clinic staring down a complex clavicle injury. Until next time, keep challenging the dogma.